Today we have a special guest, Dr. Windy Cole. We'll be talking about a recent case study that was published that she did with the dermaPACE device from SANUWAVE. My name is Kevin Richardson. I'm the CEO and chairman of SANUWAVE, and I'd like to welcome Dr. Cole.
Thank you. Thanks for having me today.
Great. And before we get started, Dr. Cole, one of the things when we were looking at this study, we really, from the SANUWAVE perspective, we weren't sure what was going to happen. We went about this in somewhat of an exploratory fashion, thinking, let's go learn. And then I think as we went along, we got more excited the more you used it. Maybe we can start by just thinking of or talking about a little bit of the genesis of this, which was, hey, we think we have a really cool device that can help on perfusion. Dr. Cole, what are your thoughts on what we could do to verify that, to study that? And I think that's how we started or engaged, and it turned into something.
Yeah, that's really the genesis of this project. I was approached by a representative of SANUWAVE in regard to the dermaPACE device. And, I am a big believer in these new therapies and in getting involved in new trials and innovative research. So it piqued my interest. It was something different and novel, and I thought that it could potentially help a subset of the population, patients with diabetes and ulcerations, that we have really limited availability of really effective therapies for. At around the same time, I was also utilizing near infrared spectroscopy, the snapshot imaging device from Kent Imaging, to track tissue oxygenation and see what therapies improved tissue oxygenation in chronic wounds. And I thought, these technologies were a good marriage, and let's see what happens when we use the dermaPACE device to treat wounds and then track what happens to the tissues in regard to oxygen and see what we come up with. So it started to have some really good results in my patient population. So we continued on with our evaluation of the devices and turned out with a 15-patient case series.
That's great. Thank you. It is an interesting marriage between the near-infrared spectroscopy and dermaPACE. Two relatively new in the wound care space ways of both diagnosing and then treating the wounds. With the snapshot, what are they measuring? And I know the answer, but why is it so important in wound healing? Why is understanding where your oxygenation level is so important in wound healing?
Yeah, so what they're measuring is the percentage of oxygen saturation, so oxygen attached to hemoglobin in local tissues. So we know that oxygen is an important biomarker for tissue health. It's essential for wound healing. So many aspects throughout the healing cascade need oxygen to be effective. So oxygen is important for the oxidative killing of bacterial species. So it helps us to keep those bacteria at bay so that wounds don't become infected, develop abscesses, osteomyelitis. Patients don't undergo amputation, so that's very important. Oxygen is also important to increase growth factors in wounds, and that's the miracle grow, if you will, for wound healing. Oxygen also helps with cellular replication and migration, so there's really important fibroblasts and keratinocytes and those cells that help us lay down the extracellular matrix, collagen structure, and epithelialized wounds. They need oxygen to be effective. And then also oxygen helps us increase angiogenesis or new blood vessel formation. Again, additional oxygen, nutrients, cellular components come into these wounds and help to heal via neovascularization or new blood flow and angiogenesis. So really tracking oxygen and increasing oxygenation in wounded tissues is a really good way, not only to determine the tissue health, but also to track if some of our therapeutic options are effective in really helping to turn these chronic wounds into more acute and active wounds.
That's great. Thank you.
Mhm.
A chronic wound, and I'm going to, I know the definition from the FDA is it hasn't healed 50% in 4 weeks and it moves from acute to chronic. But some of the wounds you were treating and some of the wounds you see, they're stalled for weeks, months, years. It's sometimes, maybe if you can talk about, not some of the worst, but just in general, some of the things you see out there and that are wounds that have just stalled.
Well, yeah, I mean, wound care clinicians, we're not dealing with acute wounds. We're dealing with chronic wounds. We're dealing with stalled wounds, wounds that aren't progressing. Like you said, they've been open for many weeks, many months, many years. All of the patients that were in this case series had all tried and failed other good wound care therapies that were in the market, and they failed to improve. And your definition is correct. These are wounds that failed to progress in healing by 50% in 4 weeks with another therapy. So these are stalled chronic wounds. They've failed other therapies that we know are tried and true. So when the tried and true fail, we try the novel and new. And therefore, that's where the dermaPACE technology comes into play. These are folks that I thought, what the heck? we might as well give this a whirl and see what happens. And we had very good results in this case series.
Great. We'll talk about the results in a second, but when I've had to describe what dermaPACE does to people, I sometimes talk about where like the getting a shock start or a jumper cables to a stalled battery. Is that analogy kind of close or near?
Yeah, I mean, these wounds are stalled, so your battery is stalled and it needs a jump, so they need a jump. And using acoustic cellular expression, pulsed acoustic cellular expression, or PACE technology via the dermaPACE device, it does just that. It transfers energy from the device into the tissues and really jump starts wound healing, gets these stalled wounds back onto that progression into replication and gets rid of that inflammation. Again, really helps to cause what was cellular senescent and maybe a disorganized extracellular matrix and low angiogenesis or no new blood vessel formation. And it kind of flips that light on and starts all of these active processes occurring again. And that's important to getting these chronic wounds back on to that healing trajectory.
That's great. So within the study, I know there were 15 patients that were used, and if I believe I'm right, they were about 3 months old in wound age. Some were older, some were a little younger, but in general, they were
stalled, right?
Yeah, they were stalled out, and you've looked at enough of them, when something's not progressing, and so that's wonderful. Maybe we can talk about some of the results, or and get into, of the 15. How did they perform? And I have some of the data in front of me, but I know you're the one who got published with this. So maybe you can talk to the things that you found most impressive or things that maybe surprised you even.
Yeah, so we tracked these patients over a series of 5 weeks. They had 4 therapies with the dermaPACE technology, and we took a baseline near infrared spectroscopy image to determine what their oxygen saturation of the local tissue was prior to therapy, and then we tracked that oxygen saturation weekly. And again, we follow these patients 4 treatments, 5 weeks, just to see what happens in that limited amount of time, because again, this was just new technology, just trying to put our toes in the water with it, so to speak. So with these 15 patients, what we saw is over the course of therapy, 7 patients completely healed. All patients did show an increase in oxygen saturation from baseline, and they were to a varying degree, but all of them did increase their oxygen saturation in the tissues. And then there was a reduction in total wound area in all the cases as well. So just about half of the in that 5-week period of time. And again, these wounds had been chronic installed, open for roughly 3 months or greater. And so we were able to make a significant difference in this small patient cohort.
That's fantastic. I mean, the results actually surprised me, and I'm the CEO. So when I saw it, I was very happy. And I think part of what you and I have talked about in the past is it's great to have dermaPACE, but it also can help lead to other modalities to help in the future as well. I know that wasn't part of this study specifically, but getting that wound from a stalled state to a healing state gives you more flexibility as a practitioner to help treat the wound, if you so choose, with other modalities. And I know this wasn't the purpose of this study, but I guess as the study concluded, did you feel more comfortable about the patients in general, where they were headed, and where your alternatives could go if you needed to?
Yeah, and I'll give you a for instance. There was a patient that was part of the study, and she had a large wound. She was diabetic, chronic wound, had been seen by multiple practitioners, treated with various treatments, varying successes, obviously not complete success. She still had this wound. She had been seen by a plastic surgeon who was reluctant to do a split thickness skin graft on her because he felt like the tissue wasn't, healthy enough to take. So she came to our clinic as a, probably at this point in time, third or fourth or fifth opinion. And I said, well, let's give this a try. Let's put you into this case series. Let's see what happens. And with the treatment with the dermaPACE therapy, we were able to increase the oxygen saturation in the tissues. We had a more healthy tissue wound base. We could see more granulation tissue, less fibrotic tissue. We had made some inroads in new epithelial tissue around the periphery of the wound, sent her back to the plastic surgeon after this 5-week period. And the plastic surgeon, who was previously reluctant to do a split thickness skin graft on her, went ahead and did the split skin graft on her, and it took wonderfully, and she completely healed. So this could be a springboard to other therapeutic modalities and treatments, where we may not have had that option. And this patient case speaks to that.
That's fantastic. That's great. I mean, it really is. Our goal is to get the wound healing in the right direction so that we can, again, save limbs, save lives. That's kind of the catchphrase you hear from us a lot of times. If we were to do things differently, and I know this is a tough question to answer, but what would you have maybe in the study design, or how would you have changed it or looked at maybe differently? What are the things that we can learn from in the future that you'd offer us to think about?
Well, this was a small patient cohort, right? 15 patients. So it's a world of research that's small. Case study. So we didn't have a control. So, to really solidify and validate the results that we had received from this study, we really need a large randomized controlled trial in the future with that control group. And that would be essential to really hang our hat and validate the early results. But this was a pilot study, so it indicates we're on to something. We have to just determine what.
I totally agree. Totally agree. I'm going to talk just briefly about the usage of it and how it can fit in the workflow of your clinic.
So I do use it in my clinic, my wound center, and we have it on a wheel cart. So it can be transferred from patient room to patient room. We try to use one treatment room for patients that we're going to be using the therapy on then that day. But sometimes, patients in a different room, I said, oh, well, you would be a good candidate for dermaPACE. So we wheel it down. Well, but other than that, I find it very easy to use. Patients feel anything. There's no pain or discomfort associated with it. treatment is very quick, dependent on the size of the wound. That denotes how many pulses that we give to the patient. But really, most wounds that I'm treating, I'm able to treat within 3 to 5 minutes. So it doesn't add much length of time onto their clinical visit. I'm certain I could train a nurse to do it. I do it personally just because, I don't know, that's how I like to do things. But it really can seamlessly fit into our care algorithms and our wound care centers and our offices.
Great. Well, thank you. Last question I have, and then we'll conclude are there any patients you think, again, diabetic foot ulcer patients, that you would say, are the right type of patients for this? When you're identifying them, is there a certain type, or is it just you focus on the harder stalled out ones, or do you think it's applicable to any type of diabetic foot ulcer in the future?
Well, with any therapy, it doesn't take the place of good wound care and good patient care.
Yep.
So of course, you have to do all of the things for the patient. You have to make certain that their A1C is normalized, right? So if a patient has an A1C of 14, 15, 16, doesn't matter what you do, they're not going to heal. You have to make certain you're doing appropriate offloading for the patient, especially if it's a plantar surface wound. You have to make certain that they have adequate blood flow. And all of these patients that were part of this case series, they had a normal ABI. So we did a cursory screening to make certain that they didn't have peripheral arterial disease. So that's key. If their ABIs or TBIs are off, you have to get your vascular surgeons involved. I wouldn't do this on someone with limited perfusion without vascular intervention. I wouldn't do it on a patient that has an active acute bacterial infection. You have to take care of that via oral antibiotics, IV antibiotics, surgical, whatever the case may be, to get rid of that active acute infection. You also have to do aggressive debridements, which is the hallmark or cornerstone of really effective wound care. So, all of those things need to be done before you really institute any therapy. So this would not replace any of those. But if you have a wound and you've really evaluated the patient and you've tried to normalize all of these comorbidities and obstacles to healing, and they haven't progressed to heal with those therapies and that sort of regimen, then I think this is a great and valuable tool to utilize to help these patients.
Great. So I guess in conclusion, we started as a small study, it finished as a smaller study, but 15 patients.
Right.
Saw improvement in oxygenation levels, saturation. They had 7 of the 15 heal. In general, it moved them in a direction from a stalled wound to having a healing cascade. I guess, is that the punchline here?
Yeah. We were able to really get these stalled wounds that hadn't made progress in many weeks of therapy, and in a small amount of time show that we are improving some of these markers and clinical data that we collect, wound measurements, and again, the near infrared spectroscopy, the oxygenation, the show that we are making progress in a positive healing trajectory.
Great. Well, thank you, Dr. Cole. It's always a pleasure working with you, and we thank you for the support. And I know we'll be doing lots of fun stuff in the future too. So again,
I hope so. Well, thank you. It was a pleasure working with you and your team.